While this trial again showed superiority of HSCT over the standard of care, it does not provide us with the answers about how does HSCT compare to these most potent therapies when we compare them in isolation. There are a number of biases that are potentially inherent in observational data, and the most obvious bias is the treatment indication bias. It is a big word, but what it basically means that we treat our patients with a purpose and for a reason. Overall, HSCT was superior, substantially superior, in reducing relapses than fingolimod. Hi, my name is Tomas Kalincik. I'm a neurologist and biostatistician. I am the head of CORE, or Clinical Outcomes Research Unit at the University of Melbourne, and the Neuroimmunology Centre at the Royal Melbourne Hospital in Australia.
And I'm Brett Drummond. You're listening to the ECTRIMS podcast, a new sounding board for the MS research community and the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. In today's episode, we're going to be chatting to Tomas about some fantastic recent analysis that he has done comparing HSCT with existing MS treatments in both relapsing and progressive MS. HSCT, or autologous hematopoietic stem cell transplants, show great promise as a novel treatment approach in MS. Today, Tomas will be telling us about how this approach might fit into the treatment landscape. Tomas, thank you for joining us today.
Thank you for having me.
So we've been talking about HSCT for a number of years. Can you tell us a little bit about what the approach is in general and what trials have shown to this point?
HSCT, or autologous hematopoietic stem cell transplantation, is actually not a novel therapy in multiple sclerosis. It is a treatment that has been around for the last 20 years and initially took the place of the only escalation strategy where the only immunotherapies available at the time were really injectable therapies such as interference and glatiramer acetate. At the time, this was considered to be a salvage therapy for people who were failing to respond to these initial platform therapies, right, or people who were suffering from aggressive, very active disease.
Yep.
Of course, our treatment landscape has changed a fair bit since those times, and we now have a number of options to escalate treatments or to start people on high-efficacy therapies from the onset of their disease. While we are in a privileged position to have all these choices, even with those, we're not always able to control disease at the acceptable level. And many people continue to experience relapses or inflammatory activity or aggressive course of their disease despite the best effort of their clinicians to treat them with the most potent therapies. So where we stand at the moment is that HSCT tends to be used in those situations where people are experiencing active disease despite being on highly active therapies and having experienced one or more instances of clear failure of these therapies.
Yep. And so I guess the trials have shown some quite promising data in terms of how effective HSCT can be for some people living with MS?
That is correct. We have initial trial evidence, which is relatively limited in terms of scope and numbers of patients, including in the trials. So far, in the relapsing remitting disease phenotype, we have had 2 randomized clinical trials. One with a relatively small number of patients included, 9 patients, and with a mixed disease phenotype, including both relapsing and progressive phenotypes, compared to mitoxantrone, which is currently not a very commonly used therapy anymore. That trial showed substantial advantage of HSCT in terms of reducing relapse activity and preventing progression of disability in comparison to mitoxantrone.
Okay.
However, what we can learn from that trial is relatively limited because of the mixed nature of the intervention cohort, including progressive and relapsing patients, and also the comparative, which is not something that clinicians would be thinking about too much these days. A more recent trial looked at a randomization of 110 patients in 1-to-1 ratio towards either HSCT or a standard therapy. And this standard therapy is really a mixed comparative, low efficacy, high efficacy therapies, some of them without add-on therapy, some of them with add-on therapy of immunoglobulins and corticosteroids and so on. While this trial again showed superiority of HSCT over the standard of care, it does not provide us with the answers about how does HSCT compare to these most potent therapies when we compare them in isolation. So this is the gap in the knowledge. And with our present study, this is the gap that we try to address.
Fantastic. So, as you say, there was obviously a real need for the analysis to compare how this treatment works compared to other existing therapies. Before you tell us about what you actually found, can you tell us about how you did that research? Because it's obviously quite complicated and requires large amounts of data, and I believe real-world data was what you were using. Can you tell us how you go about doing that?
The real-world approach, as you mentioned, or the approach that utilizes data that are existing and that are collected for either other purposes or generically through registries or through observational cohorts locally, is the approach that we chose here. HSCT is a fairly rarely used therapy and used in a very specific setting, so we had to be smart about sourcing the data for this study. In this project, we have teamed up with 6 very well established subspecialized centers in HSCT and treatment of multiple sclerosis around the world, including Sheffield, Sydney, Melbourne, Uppsala, and Norway. And these centers have agreed to provide us access to the local cohorts of patients treated with HSCT and standardize, map this data, fill the gaps with additional data acquisition, with an additional contribution of a large center in the Czech Republic. And together with the Czech Republic Center, which is also part of the MS-based collaboration, we have reached out into the entire MS-based registry to screen for sites that have utilized this therapy and would be able to provide us with the data. So you can see that this is a composite approach to collating a very rare cohort of patients with very rare treatment. Mm-hmm. On the other hand, the comparative cohort consists fortunately of treatments that are very common in the treatment of multiple sclerosis. Yeah. And here is where we were able to utilize fully the power of international registry, that being MS-based, and reach out to sites that contribute patients treated either with fingolimod, natalizumab, or ocrelizumab recorded in this registry.
Mm-hmm. So obviously that's a lot of data, and the comparison itself is not straightforward from a mathematical and statistical point of view. How do you go about actually putting all of that data together so that you can get results out that are meaningful?
There are a number of biases that are potentially inherent in observational data, and the most obvious bias is the treatment indication bias. It is a big word, but what it basically means that we treat our patients with a purpose and for a reason. Mm-hmm. So a patient who would be treated with lower efficacy therapy in the eyes of the clinician would have a different type of a disease or different severity of the disease than a patient who receives high efficacy therapy. So we had to work around this problem, and there is a very well established standard methodology that is now widely used in the field of not only multiple sclerosis but also other clinical disciplines, which is called causal inference. A fairly simple corner of the causal inference world is propensity score based methodology. In this instance, we chose propensity score matching because it is a method that allows us to emulate a clinical trial in a way that is very approachable and understandable to a clinician. Basically, what we do, we distill the information that is relevant to the allocation of one or the other compared therapies. Mm-hmm. We translate that information into a number and then match patients on this number. Okay. By doing that, we create 2 cohorts of patients who have very similar characteristics, and importantly, these characteristics are matched on a pairwise basis or mm-hmm. one-to-multiple basis. We use one-to-multiple matching approach. The a type of outcome that we analyze through this is called average treatment effect among the treated, and it tells us about what is the difference in the treatment effectiveness of the 2 treatment approaches in those patients who are actually overlapping between the 2 recruited groups, so who mm-hmm. have ended up being matched and included in the final analysis.
So I guess then, having gone through that process and done the analysis, and I know you've had 2 separate studies that you've worked on in this space, can you tell us what the results showed? Can you walk us through what the data showed for both of those?
In the first study, we have asked the question of the comparative effectiveness in relapsing remitting patients. So this is a cohort of patients with highly active disease. On average, what we saw, the patients included in the study and matched had mean EDSS score around 3.8. So that is a moderate disability with relatively high pre-baseline relapse rates of 0.7 to 0.8. Very tightly matched groups, and the numbers of groups for HSCT were usually around 140 to 150 patients matched, with the exception of ocrelizumab, where we have matched 110 patients, which is defined by the fact that ocrelizumab is a relatively new therapy on the market, and we also have not only less treated patients, but also relatively shorter follow-up of up to 3 years. In the other two comparators, fingolimod and natalizumab in relapsing remitting MS, we had a average follow-up of up to 5 years. After matching, we saw that overall, HSCT was superior, substantially superior, in reducing relapses than fingolimod, with the difference being 0.1 annualized relapse rate, so one relapse every 10 years. It was marginally superior over natalizumab, with the difference being 0.02 relapses per year. And we did not find an evidence in that smaller cohort of ocrelizumab over a shorter period of time for the difference in annualized relapse rate. This was also corroborated by additional analysis that looked at the probability of a relapse after starting one or the other compared therapy. In terms of disability outcomes, we found no evidence for the difference in the confirmed disability progression as an outcome. However, a striking observation here was that we found evidence for difference in the probability of confirmed disability improvement, where HSCT outperformed both fingolimod and natalizumab. This is really substantial finding, particularly in relation to natalizumab, because natalizumab is known to be associated with up to 25% improvement in EDSS scores during the first year after people started natalizumab. And these are data from randomized clinical trials. So what we see is that HSCT is even superior than this effect of natalizumab in this real-world cohort, to the point that up to 30% of patients have improved in their disability during that first year.
That's really interesting and important data. You also looked at comparisons in a cohort of people living with progressive MS, which is obviously a really important cohort of people that we need answers in. Can you tell us a little bit about what you found in that analysis?
The motivation for this analysis was slightly different. While in relapsing remitting disease, one is looking for a solution, an option where high efficacy therapies are failing, and we're really asking ourselves a question that if we were to accept a higher risk of using HSCT, is this justified by substantially high effectiveness? In progressive disease forms, we actually do not know to what extent these highly potent therapies works. In fact, many trials have shown negative results, or if they were positive, the magnitude of the improvement was relatively small. So the question that we are asking ourselves here is whether these people who progress with the progressive disease forms, whether it is in the presence or absence of underlying episodic focal inflammation presenting as relapses, whether they would derive any benefit from going down this pathway of aggressive treatment with HSCT, rather than considering a somewhat desperate measure of using the high efficacy treatments that are not yet proven in, or that whose effectiveness in this cohort is relatively marginal. We have made a pragmatic decision of comparing HSCT against natalizumab, because that is a therapy that is relatively well represented in progressive MS in the MS-based registry. Ocrelizumab has only recently been introduced to a small number of markets, so that doesn't provide us with the power required for this type of analysis. In natalizumab and HSCT comparison, we identify most of our cohort as patients with secondary progressive disease, with only a small number of 3 or 4 patients on HSCT being diagnosed with primary progressive disease. The average disability in this cohort was substantially larger, so people had an average EDSS score of 6.8, and however the annualized relapse rate was also not negligible. within the range of 0.5 to 0.6 relapses during the year preceding treatment, which tells us that there is probably a little bit of inflammatory flavor to that phenotype of patients who we were exploring here. And also tells us about the inclusion criteria for the HSCT treatment. Many sites who offer HSCT treatment require an evidence of episodic inflammation, that being either MRI lesion or a relapse. So having defined the cohort, the size of the cohort was actually quite a bit smaller than in the relapsing remitting cohort. We were only able to include 37 patients with progressive disease forms treated with HSCT, which is also defined by somewhat some reluctance for use of this therapy a priori by the clinicians who manage these treatments. In this context, we had to preserve the HSCT cohort as much as we could. So we have used slightly different type of matching, which is called optimal matching, that really preserves that cohort of interest. And to this cohort, we try to match as many people in the natalizumab cohort as possible. The overall balance after matching was not as good as in the matching of the relapsing remitting patients. So our analysis had to adjust for residual imbalance on age and MS duration. After doing all this analytically, however, we found a fairly convincing result of no difference in the effect on annualized relapse rate or probability of experiencing relapses between HSCT or natalizumab in progressive disease forms. To the point that annualized relapse rates in the both cohorts reached 0.08 relapse per year. Exactly. That annualized relapse rate is very small when we think about that pre-baseline annualized relapse rate, but let's keep in mind that we're talking about primarily progressive disease phenotype, so this is not the primary outcome of interest that we are analyzing here. For the disability outcomes, we did not find any evidence of a difference in confirmed disability worsening or confirmed disability improvement. Based on this, we can say that with the follow-up up to 5 years, we have no evidence to say that HSCT is superior to natalizumab in controlling either progression or occasionally ongoing relapse rate in people with progressive disease forms.
So obviously really interesting research and really interesting analysis. Thinking about the translation of that research, obviously that's a really important aspect of it. How might these results change the discussions between a neurologist and their patient? And does this have the potential to shape and alter options provided to patients moving forward?
We're hoping that this is important information that comes at a time when there are a number of randomized control trials underway, and some have really good design that will answer many of our questions. However, these trials are complex and take a lot of time to complete. So we can't expect to have evidence from these trials over the next 10 years. What I believe is that we have provided ourselves with information and evidence from observational data that will allow us to guide the treatment landscape of use of HSCT both in RMS and progressive MS forms until we have the definite final results from randomized controlled trials. What we can say based on these outcomes, that given that HSCT is associated with certain risk of infection, early post-transplant complications, and some people actually require ICU admission during the time after the transplantation, that there is still a case for use of HSCT in patients with aggressive disease and relapsing remitting forms. And this is well and truly an anti-inflammatory treatment, highly potent, that allows us to better control inflammation in those patients who've tried other therapies but were not successful in controlling their inflammation. However, when we think about the progressive disease forms, there is probably not enough for us to justify the use of HSCT in people with well and truly progressive disease, where what we expect is limit the rate of progression of their MS.
So to finish up on, I guess, what are the next steps moving forward? What are the next things that we need to know in this area?
I mentioned the randomized control trials, and that is the pinnacle of the evidence. And we will have those insights from trials in the next 10 years or so. We also need to understand the safety better. In this particular study, we were not able to compare the safety between the therapies, even though we scrutinized the safety in the HSCT cohort. So, of course, as part of the comparison, we want to see how much quantitatively riskier HSCT when we compare it to the standard therapies, particularly in the specific scenarios where the risk of treatment may be different as someone with relapsing remitting disease or primary progressive disease. And as it was asked after one of the sessions, so we would like to understand what is the impact of these different approaches on the life with multiple sclerosis from the patient's perspective. We know that the HSCT is a one-hit solution. People receive this very heavily front-loaded treatment with a substantial investment. In exchange, we hope that they will receive a number of years of freedom from disease, whereas with standard therapies, they have to engage in receiving these treatments consistently over long periods of time. I think that needs to be factored into that decision-making when we're considering which of the treatments we choose for our patient.
Okay. Well, I mean, it's fascinating and really interesting analysis. Thank you so much for sharing your time with us to record this episode, Thomas.
Thank you for having me, Brett.
So thanks everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode and also co-founder of MS Translate, a science communication initiative bridging the gap between people living with MS and MS research. You can read more about this topic and more on the ECTRIMS website, ectrims.eu. Do subscribe to the ECTRIMS podcast on Spotify and Apple, and follow ECTRIMS on Twitter, LinkedIn, Facebook, and YouTube.